which should be advancing now.
Everything looks good.
I don't have anything to disclose, but one thing that's important is for patients like mine, a lot of what we do is off-label. So I'm not intentionally talking about any of those things, but it does sometimes come up in the course of conversation. Here's a nice view of our children's hospital. I'm going to start with two kind of illustrative cases, and it occurs to me that it's not explicitly in the title that this talk is about children, but this talk is about children. So the first case is about a patient that started as a term infant who presented with multiple congenital anomalies and never really got a specific diagnosis pinned down, who was admitted to the NICU for 6 months, was transferred to a stable vent unit. At that time, had multiple comorbidities, including pulmonary hypertension, bronchomalacia, and a surgical feeding tube, and transferred from there to the PICU after something on the spectrum of a code after about a week in that unit. And then there was this back and forth that happened actually over years where the patient would go to the vent unit, have one of these sort of code events, go back to the PICU, first for a few weeks, then for many months, back and forth, and eventually after months and even years in the hospital was discharged at 3 years of age. This is all one hospitalization. At discharge, the patient had a tracheostomy, was on a home ventilator, had a central line, had a surgical feeding tube, and about 20 prescriptions. About a week after discharge, the patient returned to the emergency room with respiratory distress, went to the PICU, and three days later had a code, and eventually was found to be in septic shock with multisystem organ failure, transitioned to comfort care, and passed away. And all of this is within 2 weeks of discharge after this 3-year hospitalization. So this image here that you see, this isn't an error. This is really meant to help understand. We don't have a file for this. We don't know how to think about these kinds of events. Was this always going to happen? Was this really bad luck that this patient died so quickly after a 3-year hospitalization? Was this a waste, or was this worth it? Is this a patient who got 3 years of life in this state of ongoing instability? Here's another case. This is an extremely preterm baby who was transferred to a level 4 NICU after a few months in a community NICU for an airway evaluation. The NICU stay was characterized by multiple complex medical problems, as well as intractable psychosocial challenges that made it really hard to develop a coherent and long-term care plan for this child. Was transferred out of the unit on a home ventilator just after the first birthday. And when I say first birthday, we celebrated that birthday. Also had a surgical airway, had a surgical feeding tube with really complicated feeding problems, many medications, lots of consulting physician services, lots of other supportive services. Over time, the medical problems improved, but these insurmountable psychosocial barriers to discharge persisted. This patient was eventually discharged to the family just after the second birthday at an even bigger party, decannulated on a nasal cannula with tube feedings, lots of prescriptions, lots of appointments. Had a brief return admission to the PICU with a viral illness 2 months after discharge, but returned home in the same health state as at the time of initial discharge and is still home. So over the course of this 2-year hospitalization, there was what I would describe as collective hand-wringing for months about everything by everyone all the time, trying to figure out how to navigate this really difficult hospitalization, but also a lot of joy and parties and fun. And ultimately, this is a child who went home with their family. And so again, I ask, is this outcome good or bad? And the answer is yes, right? It's hard to know how to classify a hospitalization like this. So I'm going to pause here and acknowledge that this is work that I'm presenting on my own today, but that I've thought about a lot with my colleagues, Dr. Beanie Meadow and Dr. Erica Andrist. And we've presented this in different ways. And what's funny is the three of us have very different versions of this talk. Beanie first presented this at the American Society for Bioethics and Humanities using my lifelong dream of a title, You Don't Have to Go Home, But You Can't Stay Here. Erica's been presenting this in a couple of settings as well. And I appreciated Dr. Schumann's mention of our neonatal ethics lab. And I remind you here that it's Neonatal Ethics Lab and Friends, because we really aren't just a neonatal group. But so the agenda of what I want to talk about today is thinking about the practical dimensions of who these patients are who seem to live in the hospital. What are the moral dimensions of this space? And how do we explore these cases normatively, empirically? But then once we understand it, then what? So as an important definition, and also to acknowledge that although we are really trying to establish ourselves as leaders in this space, we didn't invent this idea. And there are other groups around the country that are spending a lot of time thinking about something called chronic critical illness. And the idea here is among all children with special healthcare needs, some of them are very complex. And there's this set of children who, due to evolutions in technology that allow children who used to die to live for a long time, there's this group of kids who have really intensive healthcare needs, use a lot of healthcare resources, and are very much vulnerable and at risk for all sorts of physical, developmental, behavioral, and emotional impairments. They're in and out of hospitals, they use a lot of technology, and they're very resource intensive. So even though they're small in number, they're in the hospital a lot. They consume a lot of hospital days. And there's some really comprehensive and interesting work coming from some groups of physicians who spend a lot of time thinking about these patients. One of the things that's vexing, though, when you try to place these patients into a larger context is that, for example, when we look at what has defined a long PICU stay in the literature, so pediatric intensive care unit, it's hard to find any study that characterizes these hospitalizations as longer than a month. In the beginning, when you looked at definitions of this, a long PICU stay was longer than 12 days or longer than 28 days. In fact, on this list, there's only one that defined hospitalizations as greater than 3 months. And I just told you about hospitalizations that were 3 and 2 years long. So it's hard to place patients like this into the literature. And this is interesting for someone like me who's a neonatologist, where these kinds of pictures are in headlines everywhere because they're really satisfying, and we knit our patients' little graduation hats. But when I think about a patient that I take care of who was born at 22 weeks, which is just over half of a full-term gestation, that's 5 months. That's a baby born at around 5 months. And if you're thinking about a patient like this, a 4-month hospitalization is a win. That's a baby who did well, who had a good outcome, because it means they survived for 4 months and went home. So when I think about what a long hospitalization is, my marker is around many, many hospitalizations that last for 100 and 200 days. And so thinking about things around some of the things that we care about at this institution, one thing that's really important is that these long hospitalizations impact different groups of patients differently. And as different groups around the world have started to study this, we see that those impacts are not always the same. So in a study out of Canada that started to look at these really long hospitalizations, they found that 88% of children who were displaced from their families were Aboriginal. So if you think about where people live and how people are impacted by the disparity in the resources you need to have medical complexity and be cared for at home, the need to stay in the hospital for a long time as opposed to going home isn't going to be equitably distributed. We also think about things like our own efforts to shorten length of stay and increase access to beds by shortening length of stay. And a really interesting hospitalization in the UK looked at sort of what was the median length of stay and who was staying in the hospital a long time. And one thing, and this plays out in our own hospital and our own NICU, is a very small number of patients occupy a very significant number of bed days. And in this study from the NHS, what they found was that you could eliminate this entire population of patients that were occupying 11% of bed days and not move the median length of stay at all, because the number is so small compared to everyone being hospitalized in the NHS. So when you're thinking about the impact patients like this have on hospital resources, it's a really small number, and looking at them as a very specific population can be really important. But so in thinking about what the practical dimensions of these ultra-long hospitalizations are, I think it's a mistake to think of them as all being the same, because there are a few different factors that drive what makes a patient stay in the hospital a long time. One of those things is that the body can be imperfect, and there are patients who legitimately can't be cared for except in an acute care hospital, often in ICU, but they seem to be able to continue in that setting indefinitely. So these are not patients that are taking a long time to die. These are patients who really can live indefinitely, but only in a setting like a children's hospital ICU. Sometimes the system fails, and these are patients who could, in theory, go home, but there are psychological, resource, or geographic barriers to prevent a safe discharge. And one thing that we'll talk about in a few different ways is that safe discharge means different things to different people, and how we define safe becomes very, very complicated. And sometimes it's that consensus is elusive, and that there are patients whose discharge is prevented by something like a parental refusal of a pivotal step that would take that patient home because of disagreements about what the right way to care for that patient is. In reality, it's often a combination of these things. And in the cases that we see as clinical ethics consultants or ICU docs or patients on the hospital or physicians on the hospital floors, it's rare that only one of these things is in play, and there are a few things happening at the same time. So here's an example that I'm using a little levity to describe. So here's a good Dr. Schumann testifying in Washington. And I picked this in part because he's an ENT. But what you see here is that Mike is sitting kind of just about where a tracheostomy would be. And what you can see is you have pretty good access to where that tracheostomy would go, right? And so in a healthy adult, placing a tracheostomy is relatively straightforward. And in some children and babies, placing a tracheostomy is relatively straightforward. But this is a random healthy baby found from some blog about like babies with no necks. And what I would challenge you to do is identify where the neck is on this random healthy baby. And as you add increasing complexity, like children who've been in steroids for a long time or sick in other ways, sometimes something like a tracheostomy is just not physically feasible. And so that important step to going home, which is getting a tracheostomy so a patient can get to a home ventilator, just isn't possible. We also encounter a lot of logistic barriers here. And that has to do with sometimes the amount of resources that it takes to get a patient who has a lot of technical and kind of human resources needs home. The picture of the mobile home park here, this is actually meant to be like a really nice one, right? This doesn't look like a bad place to live. But when you think about the resources that you need to have, for example, a ventilator at home, it can be hard to get those resources into certain kinds of housing. Right. The other thing is that we live in a state of Michigan where some of the places that people live are very far from our medical center, and in fact, very far from any medical center, and they become very hard to do things like staff with home nurses, or even for parents to travel to get to a medical center that can take care of a child with medical complexity if they need help. And so in thinking about how to get complex children home, especially if they don't live in densely populated urban areas with ready access to a children's hospital, this gets really, really challenging. And some of our toughest complex discharges are families who live in the far depths of the Upper Peninsula, and really thinking about how are we going to sort of support that family when they get home. And finally, there are just barriers to consensus about discharge disposition, right? So this is a patient in a complex patient. She's got a tracheostomy. Looking at her face, I'm going to guess she's seen a lot of steroids in her life. She's doing pretty well. She's sort of sitting supported, but she's got a toy in each hand. That makes a pediatrician happy. But you can see there are two sets of hands in this picture. There's a lot of equipment, there's a lot of people. And when you think about what it's taking to help this child thrive, that's a lot to ask someone to do at home. And from a parent's perspective, thinking about what those trade-offs are, about where this child is best served, consensus about that might not be easy to achieve. And this makes the news sometimes. So there was this story earlier in the year about an 18-year-old who was essentially living in a hospital. And there was a facility that it was identified for her to go home to that was hundreds of miles from where she lived, where her family was, where her friends were. And she said, that's not an acceptable quality of life for me. I don't want to go there. And it gets really hard to achieve consensus about appropriate placement for patients who have these really complex conditions. Another way we disagree about goals of care is what's safe and what's a reasonable amount of risk to take on to go home. So again, I talk a lot about tracheostomy because a lot of our patients like this have them. But thinking about having a tracheostomy, the tracheostomy alone is a risk factor. And although we are able to get patients home with tracheostomies and home ventilators, the cumulative mortality of this is relatively high. And when we look at why patients with tracheostomies die, the number one reason is we don't know. And the number two reason is tracheostomy accidents. So this isn't necessarily natural understood progression of the underlying disease. And so when we counsel families about tracheostomies and talk about this risk of a fatal tracheal occlusion event at home, it's not that hard to understand why some parents might not view those risks as worth taking. But what are the moral dimensions? This is bioethics grand rounds. We have to talk about some of the moral dimensions of this as well. We get consulted about this as ethics consultants all the time. A lot of this is about resources. How much is a discharge worth? Are some of these hospitalizations just too expensive? And does every patient have equal claim to a hospital bed? In other words, would this be relevant if beds were infinite? If we could build another hospital bed for every bed that was indefinitely occupied, would we still be talking about this? And is hospital bioethics even the correct arena? Is this really a public health ethics question, not one that should be adjudicated by individual hospitals and individual clinical ethics consultation teams? Is this really about disability rights and access and ableism? And are we thinking about this the wrong way when we make it a clinical ethics problem? And it's just something else that I haven't quite identified yet. Or is this about the same stuff as it always is? Is it about parental authority versus best interest? Is it about weighing risks and benefits? Is it about decision-making under conditions of prognostic uncertainty, which is certainly something that as a neonatal ethicist and thinking about extremely premature babies, I've spent my whole life thinking about? Is this about reasonable people disagreeing? So first I want to talk about the resources, because on some level, I think this is the thing that people hand-wring about the most when they think about patients occupying an acute care bed for 2 and 3 years. And so to give you a sense that we're not alone in thinking about this, this is a New England Journal article that came out this month about chronically ill children and their return visits to ER. And I thought some of these quotes were pretty powerful. Patients with complex, chronic, life-limiting, multi-organ conditions are often described as well known to us, but they're also called bed blockers, a label reflecting one answer to the uncomfortable question of which patients are most deserving of limited resources. Admittedly, I find it easier to treat children who will recover, whose problems we can fix, whether in the emergency department or in the PICU. And it would be easy to decide that such patients are more deserving of my time and the hospital's resources. That's pretty blunt. And that was in the New England Journal 2 weeks ago, not even a week ago. And ultimately, this is about the fact that there's only so much pie and we have to decide who gets it. And long stays eat a lot of pie. They take up beds and they cost a lot of money. And we have to grapple with these really difficult questions about whether or not chronic care lays a justifiable claim on acute care beds. I would ask though, relative to what? Going somewhere else? Dying? And I would also ask this group to talk about whether we can really think in 2024 about whether we have an ethical framework for thinking about bed allocation in this context, and whether we do that for anything else. And I think it can be tempting to say we just don't have the resources to do this, but I don't know that we're ready to start thinking about this in a more structured way. These hospitalizations can be astronomically expensive for a number of different reasons. One is that bed days and ICU nurses cost money, but sometimes there are also individual supplies or other things that make these hospitalizations incredibly expensive. And we can ask a question, do patients with chronic care needs have the right to infinite coverage for these multi-million-dollar hospitalizations? And there are certainly questions that get asked both theoretically and practically about whether there should be things like lifetime care caps. And I was at a very heartbreaking talk recently with someone talking about his own mother reaching a lifetime insurance cap. But thinking about when and how we apply that, and whether we're framing things right when we think about how to value someone's life over the course of an illness. And again, has anyone done this well? And has anyone done this well in the context of a child with chronic illness? But again, are we thinking about this the right way? Is this really about individual patients? Is this about hospital ethics committees, or is this about public health? And all of us got this deep entrenchment in public health ethics during the pandemic. And I've just put up one example that we talked about here at this institution about the difficulties with trying to solve a public health crisis one bed at a time. And I think what the problem with these cases is that they're relatively rare, but they make us want to create rules, and creating rules at the bedside for one patient at a time rarely works well. But what I can tell you is that these patients are starting to generate a lot of discussion and a lot of different forums about how to make these hospitalizations go well, not be longer than they need to be, care for these families with compassion, and with the best possible practices. And people are really starting to think about this as we have more and more patients like this. One thing that's interesting is that more and more children's hospitals are building programs to support families of kids like these to help their parents navigate this really complex world. And sometimes they're actually able to empirically demonstrate that they can keep kids out of the hospital. So either on these sort of powerful anecdotes or actual study of populations of patients, providing really intense case management, for example, can keep some of these kids home. However, I want to point out that almost all of these programs are philanthropically funded, which I think at least partly answers the question about whether and how our society values these children. We like these programs, but only when donors pay for them. What about the moral dimensions, right? These are the things that we talk about in many of our ethics consults across the age spectrum. These are things that we consider all the time, which is how do we make really thorny decisions when the right answer isn't very clear? So I think a lot of these decisions play out play out about parental authority and who determines when a discharge is appropriate. How do we decide when a patient is discharge ready, when a discharge is safe, and whose preferences count? We sometimes come to these impasses where patients seem ready, but their parents say, I'm not ready, this isn't right, I think we should stay here. And who's the final arbiter of that decision? Trying to decide who determines where a child is better off and how we weigh the risks of being in a hospital versus the risks of being out of the hospital. And I'll talk about that more in a minute. How sure do we need to be that discharge is ultimately possible? I think one of the things that makes these very, very long hospitalizations hard, particularly the ones where it's clinical instability that is preventing discharge, is, are we sure that discharge is ever possible? And if we're sure that it's not, does that change what we're going to do? And what if parents don't agree and say, well, if there's any chance that we could ever get home, I'm going to take it? And finally, what if reasonable people disagree? Are there impasse-related endless hospitalizations that we just can't avoid? And should there be some kind of utilitarian final arbiter that gets to decide this hospitalization has just been too long? So I've listed a whole lot of different ways that we can approach complex questions around these very, very long hospitalizations. And then what I'd argue that's probably all of those things, but it's probably something else that I haven't quite said yet. And if you look at this picture, this is from a different hospital's home vet program website, sort of promoting what they offer their home vet program. And this picture, I don't know if you'll see it this way, but it's meant to convey something pretty harmonious and pretty peaceful and pretty nice. And I think that this is also about a collective, tacitly but firmly held belief that a good life is lived at home, and that there's a moral imperative to get kids out of the hospital as a distinct existential good. And what I wonder is if people will agree that we view getting home as a universal good that everyone should want. So what's inherently bad about living in the hospital? Relative to what is one question I would ask. And what if living in the hospital is in some way better than living at home? And who gets to decide if dying is the least worst outcome when you're looking at an indefinite hospitalization? And if we're talking about dying in the hospital, if we're talking about dying at home with hospice, because these are patients at the end of the day who in some way have a life-limiting condition. And I think there are a lot of different perspectives from which to answer this question. I mean, clearly one is from the perspective of the patient, from the perspective of their family. But I think we can think about individual healthcare professionals who take care of these patients from that unit where that patient lives. And again, when I talk about these birthday parties, these patients become part of our families in these really complex and emotional ways. And for the hospital as a system. So I'm going to walk through this in a kind of structural way to help think about the balancing of good and bad for patients who live in the hospital. So there's lots of bad stuff about living in the hospital. There's no getting around that. And some of that is that you just get exposed to bad things. Being in the hospital exposes you to multi-drug resistant organisms. Being in the hospital exposes you to medical error. And there is a demonstrated dose-response relationship to that, meaning the longer you're in the hospital, the more your acute exposure to medical error is. You get exposed to noise, you get exposed to unnatural light cycling. You know, we see this in our own patients in the NICU as they get older. It's really important to pay attention to the fact that do they see light like night and day in the right way? Children in the hospital are vulnerable to developmental regression, emotionally related to stress, developmentally related to deprivation, and physically related to immobility. Children in the hospital have limited peer interaction. They have disruptions to their parent and family attachments. And inherently, this is a mismatched model of care. And that's kind of represented in the table on your right. And I'll talk about this more in a minute. But the idea that the ICU is both not a good place to live, but it's also not necessarily a good place to have chronic illness, because ICUs were not built to take care of chronic illness. But there are some good things if you're going to be chronically ill about being in the hospital. At a fundamental level, the hospital can provide safety that is hard to replicate at home. These patients are monitored 24/7 and they have centralized monitors. So the monitor doesn't just beep in front of you. That beeping fans out to a bunch of phones so that if no one responds to the monitor in the room, that beeping escalates to the monitor next door and to the phone of one person and another person. There are people everywhere. It's a safe environment. There's a larger pool of people caring for that patient, who know that patient, who are around, who care about that patient, not just caring for, but care about. And there are potentially a lot more supportive interventions that are there all the time for the child and the family. And I've got an asterisk here because I didn't want to risk offending any group that's potentially on this call for not mentioning you specifically. But there are all sorts of in-hospital therapies, particularly in a hospital like this one, that come to support chronically ill patients in the hospital. OT, PT, child life, pet therapy, all sorts of things that play into supporting a child at home. Access to specialists. You don't have to wait to go to a specialty appointment. If you need a consultant, we call them. Access to labs and testing, the results come back quickly. We can get an MRI. You can wait weeks for an outpatient MRI, or you can get one at 2 a.m, which is when we do our elective MRIs here. So there are some benefits for that chronically ill patient with really complex conditions for being in the hospital. For the parents and family, there are certainly lots of bad things about having a chronically hospitalized child. For many of them, that means separation from the child. They go home every night. Sometimes they go far. Sometimes they go home to the Upper Peninsula. There are people who spend their time, like my colleague Ashley Vance, who's one of our colleagues in the ethics lab, just looking at how much money parents spend when their child is in the NICU on a number of things, both related to the direct hospital costs, but also on indirect things. This can have impact on their other children and other family members. One of the things that strikes me all the time when I talk to parents in the NICU is other health crises they're navigating. They've got a baby in the NICU and an elderly parent over across at UH. This is stressful in any number of ways. There's a lack of a sort of holistic, natural, normal family experience that people have to experience. And there's this fishbowl quality of everybody watching you all the time. One of my mentors and a leader in neonatal ethics, Annie Janvier, wrote this devastating journal article several years ago when her own daughter was born extremely prematurely in the NICU. And she talks about this hatred she developed of going in and having everyone watch her, and this sense of going in, but that she went because she felt like a good mom goes in, and so I go in so people will see me go. And it's a really devastating read that talks about this experience of parenting in the NICU. But there are good things for parents and family. One is just having help. We don't have any organized system of respite care in this country. And so being in the NICU means you're not, being in any hospital means you're not alone in taking care of this chronically ill child. You have the peace of mind knowing that when you leave, there's a team of people taking care of your child, not just that one home care nurse, not that one babysitter. You get this sense of community. A lot of our parents talk to us about the friends they make in the waiting rooms and at Ronald McDonald House. Access to other resources, tangible resources like food and housing, but also, again, some of those resources I mentioned, like, we have some things like in-house psychologists who can come and support families when they're struggling. We have a lot of resources that we can offer that aren't available to you when you go home. And for some parents, Ronald McDonald House is housing security that they don't have when they go home. And this was covered in a really dramatic New York Times article a few years ago, sort of in the context of the Great Resignation, that home nursing is often an ideal that doesn't materialize. And so in theory, your insurance will pay for you to have a lot of nursing at home, but actually staffing those shifts becomes almost impossible. And people parent in shifts that don't see each other. They worry all the time about these catastrophic tracheal events that I talked about, and that your house becomes an ICU. On the healthcare side, thinking about what we do, we can certainly identify the bad stuff about having 2 and 3 year hospitalizations, or even 6 and 12-month hospitalizations. It's capacity strain. We don't have the beds. We can't get patients through. It's resource strain. And when I think about time, money, and feelings, right? We're doing unacknowledged triage all the time. You have to decide who you're going to pay attention to. There's emotional and moral distress, and the well-known individual and collective consequences of that. And fundamentally, there's this idea that it's just the wrong care model. But there may be some good stuff too. I think there's the potential for joy and emotional reward. We get to develop some longitudinal relationships with people that we don't always get otherwise. These patients can be profitable. That's just true. And not always, but sometimes we really do get to save lives, and not, sometimes we have someone in the hospital for 2 years and they go home and live a long life, and they wouldn't have had it if we hadn't done that. So to summarize all of this, a population of children live in the hospital, competing for acute care beds and attention with no good alternatives. So now what? So what are the long-term fixes? To me, the Mount Everest of this is building the resources outside of the hospital needed for safe and reasonable discharge. So in that you can't stay here piece of you don't have to go home, but you can't stay here, is you build that here, and you bolster those in-home supports. You create these non-existing long-term care facilities that give these patients a safe place to go. You create the respite care that doesn't exist, and create complex primary care and medical home models for chronically ill children. The reality is across the country, and I'm not even talking about what happens in other countries, this is really variable depending on where you live. States have different ways of approaching this, different strategies in terms of, do they invest the limited resources they have into home nursing models versus institutional models? I've trained in Illinois and then worked here, which approached this very differently. Neither tends to have everything they need to do it well. I'm not aware of any state that consistently offers respite care in a way that works. But in general, if you think about long-term facilities, the adult world has done this better. And there are models of care for chronically ill adults, like things like long-term acute care facilities that just don't exist for children, that do exist for adults. Those aren't perfect either, but there's no such thing as a baby LTAC. So if you think about case one, that was the patient who had something on the order of a code all the time. And you think about this model of chronic critical illness, right? I think about this added subgroup of chronic critical illness with ongoing instability. So no amount of home nursing is going to make that patient able to go home. That's not, if we could just sort out the psychosocial things, that patient can go home. That patient is getting ICU level care every single day. And so these patients really live in a liminal space. They're too sick and unstable to go home, but they're not actively dying. They're too chronic to fit into an acute care model. So thinking about this, quote, baby LTAC idea that has high enough acuity to support a child who's truly critically ill, but mechanisms to support continuity, and it isn't in competition for acute care beds. And I have this like little qualifier on that because these patients probably realistically do sort of come in and out of acute care spaces, but as we've been able to expand what we do and support patients like this, we haven't created the infrastructure to take care of them. But I suspect a lot of people on this call have taken care of patients like this. But also maybe we really do kick the can down the road, not on purpose, and we don't have the care model to create patients who need to create the right care model for patients who need to be in the hospital for a long time. And the acute care setting just isn't designed for this. And this is a slide I adapted from one of Erica Andrist's, but there's all kinds of continuity, right? There's informational continuity. Do we hand information off well from one week to the next, from one service block to the next, from 1 month to the next, from one shift to the next? Do we share our management plans well? And how do we do that? Is that over guidelines? What's the way to really create the right continuity for these patients? And Erica, I think she invented this term, but this idea of relational continuity. How do we share these relationships over time? And there's more and more work around this and more thought about like things like what does a continuity attending look like? One thing I'll say is a lot of people talk about the potential value of continuity attendings. I have yet to find a model that works well or any model that pays for it. And so generally people who do this do it because it's the right thing to do, sort of in the margins on their own time. But there's more and more recognition that there are a huge number of pieces that go into the care of a patient like this. That's more than just what are we doing today? And we haven't quite figured out how to do this well over weeks, months, and years. But we're trying. And both in the adult world and in the pediatric world, we're starting to see papers come out where we really talk about what are some potential best practices to both reduce the length of these hospitalizations, but also make them count. And a lot of people think about this not from my very singular view of patients who were born in the hospital and had never left, but patients who come in and out of the hospital, that well-known to us model of frequent flyers even in the ER. And some of this has to do with things like standardizing provider handoffs, and sort of providing more continuity shift to shift, week to week, month to month. And thinking about things like sleep hygiene and social engagement and bridging that outpatient to inpatient setting better. And the same chronic critical illness thing has looked at this, looking at the time of admission, during that hospitalization, and later on, thinking about all the different pieces that go into taking care of these patients well over the long haul as they come in and out of the hospital. And one thing I think that differentiates this research group from what we're trying to do here is they've got this very broad focus on patients who not only live in the hospital, but have this chronic critical illness over multiple care settings and how to take care of them at home, in the hospital, back and forth in the ER. And we've really been focused on these very, very long hospitalizations. Another way to think about what some of the long-term quote fixes are is to think about, have we done enough to develop consensus guidelines around management of some of these relevant conditions? So one of the ones that I think about is timing of tracheostomy for infants with severe bronchopulmonary dysplasia. So for the non-initiated, that's a complex respiratory condition that we see in some of the sickest patients who are born extremely preterm. And some of those patients end up needing a tracheostomy for long-term mechanical ventilation. And there's no consensus recommendation for when that tracheostomy should happen. And it makes it very hard for us month to month to decide when it's time for a trach because no one knows. And so I think thinking about if you can identify a condition or a group of patients who are very much at risk for being in the hospital a long time, can there be professional consensus around when it's the right time to think about these important inflection points in those hospitalizations so that there is some consensus around when we ought to be thinking about certain interventions so that patients get less whiplash and also these hospitalizations aren't longer than they need to be. And if it seems completely impossible to protocolize these highly emotional, ethically fraught decisions, I would point you to statements like the multi-organization non-beneficial treatment statement that we cite all the time at this hospital and cited heavily when we developed our own policies, which looked at how to systematically approach patient and family requests for potentially inappropriate or non-beneficial treatments. And I think if someone had said 20 years ago or 30 years ago, it's impossible, you can't make a flowchart for something that complicated, we did. And it actually turned out to, I think in the long run, be really helpful for both patients and their families and institutions to say, you can systematically approach a really complicated ethics decision by building society consensus, really putting it through aggressive stakeholder engagement and thinking through basic decision points in these complicated decisions, making sure that patients get heard and have the opportunity to appeal. And I think that there's potential to think things through more than we have when you think about some of these decisions. A harder question is whether there's ever going to be room for something like a scarce resource allocation strategy for very long hospitals. And I think it's attractive to say, oh, well, we just need to make some rules and decide when is a hospitalization too long and really just think about how to protocolize this. And I would caution that this is incredibly difficult and outside of a public health crisis. There are so many ways that we're not ready to do this. And the extent to which we haven't done the other things, I think makes this the last thing we ought to be thinking about. And poking the holes in it was what helped me get to the realization that we're just not ready. And so thinking about in what other settings we do this, how does this hold up in other ways that we parse out complicated healthcare? How few of these patients are there? It seems like there are many, many reasons that we're not ready for prime time. When we think about things like lifetime coverage and is there at some point where your hospitalization has cost X much you can't have anymore, I think comparative models looking at other health systems that are more exhaustible than ours and how well have they fared with things like just deciding that certain things are too expensive or too complicated, whether they apply to patients like this and whether they're applicable to our own health systems, I think it becomes apparent that this is also not the right way to address complex, long hospitalizations in the United States. But I think thinking about this, it's important to work through the exercise and think about what problem we were trying to solve and what's the best way to solve it. But society really does fail some patients who could be home. And some of these hospitalizations are longer than they need to be. And so thinking about high-level advocacy strategies in the long run for patients like the second case that I presented, where that patient could have been home if we could have overcome the obstacles to sending that patient to their own parent's house. And thinking about things like medical foster care, which is a nice idea, which is essentially non-existent in this region. We talk about medical foster care, but it's not a thing that we can refer to. There just isn't any. And so thinking about what it takes to create the resources for people who don't have a lot of their home to get complex children home, what it takes to build long-term care facilities in the communities where people live, not hundreds of miles away, that they can get to where they can continue to parent their children in a meaningful way, get to and from their facilities, or get the resources in their homes that to get them, and to separate out I don't have the heroic amount of resources it takes to take care of this medically complex child at home from someone needs to file with CPS, because right now we don't have a way to distinguish those things, and that fails a lot of families. So now what? And I'm closing in on my last slides with less to talk about than I expected, which is good. So I can take your questions and we can have a conversation about this. But you know, the spirit of the way that I was taught ethics was that, you know, when you don't know what to do about a complicated problem, you start by counting things. And I don't think that we've counted enough. And I don't think that we have gotten to the point where we understand this population well enough. And this is the initial focus of the neonatal ethics lab as we think about where we're going next, is characterizing this population better, both at this institution and ideally nationally, is when we look at a hospital population based. So when you think about this really well nuanced research agenda that the Chronic Critical Illness Collaborative has, really focusing on the hospital population. Who are they? How many of these patients are they? What happens to them? And how does that inform research on what they need? And, you know, and coming up with some definitions that have kept up with the world, because clearly greater than 13 days is not cutting it. So is it measured in days? Is it measured in weeks? Is it measured in months? Can we identify age groups or disease entities or contexts where it's important to characterize these populations separately to figure out what they need? And figuring out who lives and who dies, what's their health state, what's their healthcare utilization, and understanding this population better to understand what needs to happen next for their own good and for the good of the collective. So to summarize a really complicated topic in one slide, thinking about the ethics of living in the hospital. A small but important population of medically complex children lives in acute care hospitals in a system that fails them and everyone else. There's a care model and resource mismatch. There's no available appropriate resource allocation framework. And that's probably the wrong long-term fix anyway. My animation's got a little out of order here. There's an unrealistic, monolithic expectation that going home should be the North Star. And this is a parental authority best interest problem that we haven't really acknowledged or gotten into enough. There's limited resources and will for things that could help to address the challenges in the short term. These aren't fast and easy or cheap. And we don't have that for the long term either, and that's really Mount Everest, so we better get started. The good news is that this topic is gaining traction here and elsewhere as an important area for research and clinical expertise. So I'm going to stop mostly by thanking Erica and Beanie, who have really been my sort of partners in thinking about this topic and imagining where we can take it and identifying it as really as ripe for working on here and hopefully bringing that to the national stage. And I will stop sharing and hope that we can have a good conversation in the time that we have left.
Dr. Laventhal, thank you. That was a masterclass in presenting cogently and clearly for folks who are content experts as well as those who aren't. And I think you've convinced everyone of the magnitude of the challenge. And I apologize for the overhead announcement, which is perfectly timed. I will take moderator's privilege for first question, and I invite others to put more in the Q&A and send them to me directly. So my first question relates to goals. And I know as ethicists, we often frame things in terms of goals. And you've made quite clear that the goal does not necessarily have to be go home. But how about for kids where the goal isn't even to survive to adulthood, for example? And how do we think of a palliative course of care or a hospice course of care for these chronically ill children who aren't dying today or tomorrow or next week, but probably aren't getting their driver's license and also aren't going to get home before that happens?
I think that really cuts to some of the hardest moral part of this as we really think about what ends are worth chasing and who gets to decide. And that first case, I think, is so hard for that reason, because we can argue that 3 years in the hospital to not live outside of it wasn't a good outcome, but for the parent of a child who lived for 3 years to say, well, that's 3 years I wouldn't have gotten if we hadn't done this. And so I think that there are, certainly in the pediatric world, I think that we have come around to accepting a norm that months and years of survival are an acceptable outcome for families to pursue in and of itself, and that survival to adulthood doesn't have to be the goal, and that we are willing to support survival to sort of whatever length people can get, provided that that is not a life of suffering that we can't relieve. And that's, suffering is a very morally laden word, but, in a context where children don't appear to be in pain, don't appear to be in existential anguish to the extent that we can assess that in a child, acknowledging that a child's life will be short, but that we can support it with available technologies and not cause them pain, we let parents pursue that. And I think that that's something that isn't talked about a lot in Children's Hospital anymore. The next frontier has been, does cognitive, intellectual, functional potential impact that decision? And again, I think for the most part, we've said no, and parents get to decide what developmental potential is worth pursuing. Where I think is less clear is, does home have to be achievable, right? And does home have to be achievable for that to be worth pursuing? And I think that's a lot harder. I think if we say there's no chance for survival outside of a hospital, I think that that's a harder question that we really need to start to address.
Thank you. There's a question in the chat. So you noted in your first case that there was not a clear or unifying diagnosis. How important do you think that is in terms of labeling as well as in terms of prognosticating for these incredibly complicated kids with problem lists longer than most people's charts?
That's a good question, one I've thought about a lot, thinking about the value we put on having a label for things, and how much happier we are when we have a genetic diagnosis versus a constellation of anomalies. Sometimes I think we put too much value on that, and the anomalies themselves can tell you a lot. But the reality is all of this is changing with the rapid availability of whole genome sequencing that we have at our fingertips now for just about everyone. Having a diagnosis doesn't always give you a prognosis, though. So we are now in a world where just about everything has a name, and it doesn't necessarily tell us what the prognosis is. But again, I think this comes down to who decides in the face of uncertainty. What we're learning is that many conditions uniformly described as being consistently lethal aren't, when we offer fairly basic interventions that support long-term survival. And we're not always able to predict with a lot of certainty who's going to survive infancy, who's going to survive childhood. And we come down to how much chance is worth pursuing, or as my colleague Stephanie Kokora talked about, parents afraid of squandering a chance on survival. What if you're wrong? What if your prognosis is wrong? But we're at a really complicated crossroads now where we have a lot of diagnostic precision, but not necessarily the ability to support that diagnostic precision with a lot of prognostic certainty. So this is actually getting harder, not easier.
Thank you. More questions are coming in. Next one relates to insurance. And obviously that was not what you were here to cover, but this is all expensive and rarely is being paid in a way that is really understandable to a system or to a person. So especially for care that is going to exceed 7-8 figures easily, how do we conceptualize this both as an institutional level where much of this cost is absorbed, as well as at a societal level? And also when we're talking about a new model with an LTAC, for example, how on earth is anyone going to convince someone to pay for that?
And so this does rapidly get out of sort of my area of expertise, but I would say is it can't possibly be more economically inefficient than having a child in an acute care ICU. So I think part of the way you build an argument for things like off-site facilities is that surely there's a way that that's less expensive. I don't know that to be true, but I imagine that was part of how adult LTACs were conceived. I can't imagine anything more expensive than being in an ICU. Part of this is how pooled insurance works, right? Part of this is ideally, as you build long-term goals of care, is that you stop doing things that everyone agrees don't help. You stop repeating tests because the person who came on service didn't know that someone else had already done it. And I'm going to do everyone's most favorite thing, which is to answer a question that didn't exactly get asked, which is some of this has to do with the astronomical amounts of time that nobody pays for on sort of sweat equity on coordination, right? If if physicians and other people billed by the hour for the amount of time they spend on the phone trying to pin down who said what to who and sort of disentangle complicated conversations and remember what happened. And so part of this is that what gets paid isn't some of the work that's actually quite productive and bringing some continuity to these patients, which probably makes these hospitalizations shorter in the long run. But I think, yes, these hospitalizations at an individual level are astronomically expensive. And it really comes down to, do the numbers justify, like, how much money do you save collectively versus the total cost of healthcare? And one thing I'll just point out is that children are almost never the way in the comprehensive health system to save money because there are so few of them compared to adults. So if you look at like adults in ICUs and kids in ICUs, like the kids is just like a tiny fraction of the money. But yeah, these are multi-million-dollar hospitalizations.
Great. Well, not great, but great answer. The next question relates to technology. So the question says, I speculate we'll see more of these cases rather than less, given advanced medical practice and more technologies that can keep very sick kids alive and stable, in quotes, in ways that simply can't be replicated at home. It's not necessarily a parent barrier, but a technology barrier. Thoughts, and how has this played out so far, and how do you see it changing over time?
I think that's absolutely true. And it's actually how I started thinking about this topic, was ethics consults we started getting about what I called bridge to nowhere BiPAP. These sort of, if you think to a parent about a patient who's being supported non-invasively on a technology that for some reason we can't provide at home, but that child can safely and comfortably get it in the hospital, that wasn't there, right? We didn't have that technology. So that was actually what got me thinking about this topic originally, was these new things that we couldn't do. And some of this is nature abhors a vacuum, right? And I think there was a time where we would have said it was absurd for someone to be at home on a ventilator, and now you can. And so I think some of this is we find ways to get people home. Some of this is, I think, the need for appropriate, safe, family-friendly institutions. But yeah, I mean, there's a population of children that we couldn't support before that we can support now, and we don't have a long game for what to do for that. But don't do it is not going to be a workable way to deal with that. It's going to be, now what?
Great. The next question comes a little bit back to paying. So the recent killing of a healthcare executive prompted nationwide discussion on limits on care that result in shortened lives. How do you perceive the situation for clinicians who face these issues? How do we prevent similar issues from happening? And I'll focus specifically on, when taking care of these critically ill kids, is insurance coverage even something that folks are thinking about, or is it essentially a blank check that gets paid after the fact by somebody else?
Yeah, I mean, all right, now in my more administrative hat, I'm aware, for example, that things that happen at the hospital administrative level, that like there is real time hand-wringing about these prolonged hospitalizations. Some of that has to do with capacity as much as it is the bill. But for me as an ICU doc, how often am I presented with, do you know how much this hospitalization costs? Never, right? I think occasionally, long after a hospital is over, I find out that some medication among the 40 I ordered wasn't covered and I have to beg for appeal, and sometimes we don't. I think actually there are some things that are probably much easier for us to get on an inpatient basis than outside. Certain, like we do some genetic testing in the hospital because it's easier to get it covered in the hospital than it is when people go home. I think when these patients are home, when these chronically critically ill patients are home, prior auths are their whole lives. And navigating insurance company, and did you have a referral for that subspecialty visit, and can you have those visits on that day, and are you in state for the video visit or not, and all of those things. I mean, I think those things become incredibly burdensome for families. Where can you get your prescriptions filled? And I think that's where I think some of those intensive case management programs become really important for people, is that for most people, especially people who are trying to have jobs or raise other kids, the administrative burden and frustration of navigating insurance while trying to do this becomes completely overwhelming.
Great. We have time for one other question, and it relates to pediatric exceptionalism. So why are these problems in pediatric facilities so much bigger deal than they are in adult, or is that not necessarily true? And you have 90 seconds.
And well, so what I'll say is some of this is that adults do have this LTAC pop-up. So I think that adults tend to have somewhere to go where they can be sicker than where kids can go. I think kids are also resilient in a way where kids can be really sick for a long time in a way that I think the adult body, with all we've done to it over an adult life, can't tolerate being as sick for as long. But I mean, I don't know the answer to the question of how many adults are hospitalized for 3 years. You know, it's probably not zero. But I think the world is better equipped to deal with medical complexity in adults for longer, for mostly just economies of scale issues.
Wonderful. We are just about at time. I want to thank you for.
So can I ask a question then?
Yeah, please.
I'm barging in here. So so Naomi, this is one that everyone can ponder. I think these studies that you propose are awesome and are going to generate a lot of data, but they seem that they're going to generate the kind of data that a steely-eyed utilitarian might use to, you know, ration care in a way that we all worry about. And I'm just guessing, and I'm asking, you know, do you see that as a real threat, or are there already safeguards that will prevent us from going down that path of sort of doing the hard calculations about who has more qualities and where we should put our money?
Yeah, I will say, I think that people, I hate to even make it sound this good, but people talk a good game about that and generally don't make good on it. What I hope can come out of this is motivation to do the 18 things that come before you have to do that. Like build the systems you need to build so people won't have to stay in the hospital that long.
Thanks.
Wonderful. Now that we solved that problem, thank you for a really fantastic presentation and discussion. You know how to find Dr. Laventhal for follow-up, and I wish you a good afternoon and a happy and healthy holiday season. All the best.
Thanks for having me.